Hello, and welcome to the American Heart Association's ACLS Science Overview video. The ACLS course emphasizes the critical importance of high-quality basic life support in improving survival from cardiac arrest. High-quality, properly performed CPR will save lives, and all victims of cardiac arrest should receive high-quality CPR. Unfortunately, not enough victims get CPR at all, and even fewer get high-quality CPR. The ACLS course makes it clear that effective ACLS begins with high-quality BLS. The guidelines emphasize effective chest compressions, which are essential to produce coronary artery and cerebral blood flow during CPR. The better the chest compressions are performed, the more blood flow they deliver to vital organs. To give effective chest compressions, all rescuers should push hard and push fast. That means compressing the chest an adequate depth and at a rate of about 100 compressions per minute. Also, allow the chest to recoil fully after each compression. This allows the heart to refill with blood after each compression. Use approximately equal compression and relaxation times. Finally, minimize interruptions in chest compressions. When chest compressions are interrupted, blood flow stops and coronary artery perfusion pressure quickly falls. Rescuers should try to limit all interruptions to 10 seconds or less, except when needed for specific interventions, such as insertion of an advanced airway. It is essential that ACLS providers integrate effective chest compressions with other basic and advanced therapies. The second major emphasis for CPR is the use of a universal compression to ventilation ratio of 30:2 for all single rescuers and for all adult CPR. The goal is to deliver longer series of uninterrupted chest compressions. ACLS providers should reorganize ACLS therapies around 2-minute periods of uninterrupted CPR. The third major emphasis for CPR is that all rescuers deliver each rescue breath during CPR over 1 second. The volume of rescue breaths should be sufficient to produce visible chest rise, while being careful to avoid delivery of breaths at too rapid a rate to too large a volume. Inevitable fatigue will result from providing a greater number of uninterrupted chest compressions. When more than one healthcare provider is present, healthcare providers should change compressor roles about every 2 minutes or 5 cycles of CPR, where 1 cycle of CPR equals 30 compressions and 2 rescue breaths. Rescuers should make the switch when chest compressions are interrupted for rhythm checks and should try to complete the switch in 5 seconds or less. Those are the major points of emphasis for effective BLS, which again is critical to the ultimate success of ACLS. Now we'll look at the major points of emphasis specific to ACLS, beginning with defibrillation. When defibrillation is indicated, healthcare providers should deliver a single shock rather than up to 3 stacked shocks. To treat cardiac arrest associated with VF or pulseless VT, deliver a single shock followed by immediate CPR, beginning with chest compressions. It's important to understand that if you reduce the interval between the last chest compression and shock delivery to 5 seconds or less, predicted shock success is higher than if the interval is longer than 5 seconds. The longer the interval, the lower the predicted shock success. ACLS providers should not interrupt chest compressions to check the pulse or rhythm until about 5 cycles of compression and ventilation, or approximately 2 minutes of CPR, have been provided after the shock. The pulse should only be checked if there is an organized rhythm. This requires that ACLS providers organize drug therapy, shock delivery, and other interventions around these 2-minute CPR periods. This organization requires planning and practice. These recommendations may be modified for the in-hospital setting, particularly in the intensive care unit where continuous electrocardiographic and hemodynamic monitoring may be in place. There are 3 main reasons for this protocol. First, biphasic defibrillators are now widely available. These defibrillators eliminate VF after the first shock more than 90% of the time. In cases where the first shock does fail, the VF is likely of low amplitude, indicating that the myocardium is ischemic. Resumption of CPR is likely to confer a greater value than another shock by improving the metabolic state of the heart. Second, even when a shock eliminates VF, most victims demonstrate a non-perfusing rhythm, such as asystole or pulseless electrical activity, for the first minutes after defibrillation. These victims need immediate CPR to maintain blood flow. A brief period of chest compressions can deliver oxygen and sources of energy to the heart, increasing the likelihood that the heart will be able to resume a perfusing rhythm. Third, analysis after a shock will prolong the interruption of chest compressions, perhaps for 37 seconds or longer. Such interruption can create myocardial ischemia and cannot be justified in light of high first shock efficacy and need for CPR during a period of post-shock asystole or PEA. The next major point of emphasis with respect to defibrillation involves which to use first, compression or shock, for presumed VF sudden cardiac arrest. When any rescuer witnesses an adult cardiac arrest and an AED is immediately available on site, the rescuer should use the AED as soon as possible. This recommendation will apply to all in-hospital rescuers and for witnessed out-of-hospital arrest when an AED is on site. When more than one rescuer is available, one rescuer should provide CPR until another rescuer brings the AED to the victim's side. Ideally, one rescuer will continue CPR while another rescuer turns the AED on and attaches the AED pads, and the device is ready to analyze the victim's heart rhythm. When the EMS call to arrival interval was 4 to 5 minutes or longer, a period of 1.5 to 3 minutes of CPR before defibrillation was associated with improved survival in 2 of 3 studies. So EMS system medical directors may consider implementing a protocol that would allow EMS responders to first provide about 5 cycles, which is about 2 minutes of CPR, instead of immediately attempting defibrillation when the EMS system call to response interval is longer than 4 to 5 minutes. CPR may be performed while the AED pads are being applied. The recommended dose for initial and subsequent shocks using monophasic waveform for treatment of VF pulseless VT in adults is now 360 joules. For a manual biphasic waveform, the initial selected shock dose for adults is 150 to 200 joules for a biphasic truncated exponential waveform, or 120 joules for a rectilinear biphasic waveform. The second dose should be the same or higher dose. There is no evidence that one type of biphasic waveform is superior to another. ACLS providers using a manual biphasic defibrillator should use the dose at which the device they are using has been shown to be effective in eliminating VF. If this dose is not noted on the front of the defibrillator, or if the ACLS provider is unfamiliar with the device-specific dose, the consensus recommendation is to use a default dose of 200 joules. The goal of this recommendation is to simplify attempted defibrillation and to support the use of device-specific doses of proven effectiveness. ACLS providers should practice chest compressions and shock delivery to minimize the interval between the last chest compression before the shock and the shock delivery. As mentioned earlier, the shorter that interval, the better the predicted shock success. That sums up the major emphasis for defibrillation. Now let's continue with other areas of major emphasis for ACLS. You'll find that the ACLS treatment of cardiac arrest has been designed to minimize interruptions in chest compressions. This requires the resuscitation team leader to plan interventions such as rhythm checks, ACLS therapies such as insertion of an airway, and even drug administration around uninterrupted periods of CPR. Quite simply, the potential effects of any drugs or ACLS therapy are dwarfed by the potential effects of immediate, high-quality CPR and early defibrillation. Because insertion of an advanced airway may require interruption of chest compressions for many seconds, the rescuer should weigh the need for compressions against the need for insertion of an advanced airway. Advanced airways include combi tubes, laryngeal mask airways, or LMAs, and endotracheal tubes. Airway insertion may be deferred until several minutes into the attempted resuscitation. Once an advanced airway is in place, rescuers no longer deliver cycles of CPR. Instead, the compressor delivers 100 compressions per minute without pauses for ventilation. The rescuer delivering ventilation delivers 1 breath every 6 to 8 seconds, or 8 to 10 breaths per minute. A lower than normal ventilation rate is recommended during CPR because cardiac output and pulmonary blood flow are also lower than normal during cardiac arrest. Studies suggest that the LMA and combi tube can be inserted safely and can provide ventilation that is as effective as bag mask ventilation when used by healthcare providers trained in their use. Successful insertion of the LMA by inexperienced as well as experienced providers has been documented in the out-of-hospital and the in-hospital setting. There is a high incidence of unrecognized endotracheal tube misplacement and displacement. Training, frequent experience, and retraining are important to address these problems. In addition, to reduce the risk of unrecognized endotracheal tube misplacement or displacement, ACLS providers should use clinical assessment plus a device such as an exhaled CO2 detector or an esophageal detector device to evaluate tube location. Resuscitation programs should have a process for continuous quality improvement to monitor frequency of tube misplacement and displacement and minimize these problems. If at all possible, drugs such as lidocaine and epinephrine should be administered by the IV or IO route instead of the endotracheal route, because IV-IO administration provides more predictable drug delivery and pharmacologic effect. However, endotracheal administration of some drugs is still recommended if no IV or IO access can be established. Drugs should be administered as soon as possible after the rhythm is checked. They should be administered during CPR. ACLS providers should prepare the next drug dose before it is time for the next rhythm check, so the drug can be administered during CPR as soon as possible after the rhythm check. This requires organization and planning, and again serves to lessen interruptions in chest compressions during attempted resuscitation. Vasopressors are ideally administered when an IV-IO line is in place, typically after the first or second shock. Epinephrine may be given every 3 to 5 minutes. As an alternative, one dose of vasopressin may be given instead of either the first or second dose of epinephrine. When VF pulseless VT persists after 2 to 3 shocks plus CPR and administration of a vasopressor, consider administering an antiarrhythmic such as amiodarone. If amiodarone is unavailable, lidocaine may be considered. While additional studies on amiodarone document improvement in short-term outcome, specifically ROSC and survival to hospital admission, neither amiodarone nor lidocaine have been shown to improve survival to hospital discharge. Now let's take a closer look at the priorities of the ACLS pulseless arrest algorithm. The treatment sequences illustrated here suggest the timing of CPR, rhythm checks, attempted defibrillation, shown as shock delivery, and drug delivery for persistent VF and pulseless VT. Note that the ACLS pulseless arrest algorithm has a core, during CPR, green box that emphasizes high-quality CPR. Therapies are designed around periods, 5 cycles or 2 minutes of uninterrupted CPR. CPR should resume immediately after delivery of 1 shock. Pulse and rhythm are not checked after shock delivery. Rhythm checks are performed after 5 cycles, about 2 minutes of CPR. Pulse checks are performed when an organized rhythm is detected. Rescuers must be organized to limit interruptions in chest compressions for interventions such as insertion of an advanced airway. Note also that drug doses should be prepared prior to rhythm check and be administered during CPR as soon after a rhythm check is possible. If possible, rescuers should perform chest compressions while a manual defibrillator is charging if the charge time exceeds 10 seconds. In in-hospital settings with continuous monitoring in place, such as electrocardiographic or hemodynamic, this sequence may be modified by the physician. If PEA or asystole is present after a shock and CPR, rescuers should follow the asystole PEA branch of the ACLS pulseless arrest algorithm. This concludes the American Heart Association's ACLS Science Overview video. Thank you for your attention.